We're Sentia Health. We're in the business of streamlining and automating processes and have even automated the production of new software. Usually we talk about the state of healthcare and health insurance in the US, but today is a little different. We are going to talk about an article published by the Commonwealth Fund last year that details exactly why the US healthcare system is an international embarrassment. The Commonwealth Fund is a private foundation that aims to promote a high-performing healthcare system with better access, improved quality, and greater efficiency, particularly for vulnerable populations such as low-income people, the uninsured, and people of color. We will use a point-counterpoint format to go over their article in detail and give our response to each. We will show that not only does the United States have the best medical system on the planet, but that the problems are healthcare finance and patient education. We will then offer real, well-thought-out suggestions and execution on how to solve those problems. In January of 2023, the Commonwealth Fund published U.S. Healthcare from a Global Perspective 2022, Accelerating Spending, Worsening Outcomes. This article deals mostly with mortality as it relates to healthcare spending. It is not really about medicine, and we here at Sentia Health are kind of in the same healthcare finance business. Doctors know what to do. It is the bankers running health insurance that are killing people. In their introduction, the Commonwealth Fund highlights their conclusions and states what they hope to prove. They state,
in the previous edition of U.S. Healthcare from a Global Perspective, they reported that people in the United States experience the worst health outcomes overall of any high-income nation. Americans are more likely to die younger and from avoidable causes than residents of peer countries. Between January 2020 and December 2021, life expectancy dropped in the U.S. and other countries. With the pandemic a continuing threat to global health and well-being, we have updated our 2019 cross-national comparison of healthcare systems to assess U.S. health spending, outcomes, status, and service use relative to Australia, Canada, France, Germany, Japan, the Netherlands, New Zealand, Norway, South Korea, Sweden, Switzerland, and the United Kingdom. We also compare U.S. health system performance to the OECD average for the 38 high-income countries for which data are available. The data for our analysis come from the Organization for Economic Cooperation and Development, OECD, and other international sources. See how we conducted this study for details. For every metric we examine, we use the latest data available. This means that results for certain countries may reflect the height of the COVID-19 pandemic, when mental health conditions were surging, essential health services were disrupted, and patients may not have received the same level of care.
It seems to us at Sentia that these problems all boil down to two root cause categories: money, education. If we bring down the cost of health insurance, notice that is not the care itself, that is a different subject that we will discuss in a future episode, and educate the patient on behavior that causes and exacerbates chronic disease, then we would be at par or better than criminally expensive universal health coverage that we know from experience in the UK and Canada isn't a viable option. Here are the findings of the Commonwealth article with our comments in the conclusions section following their charts.
In all countries, health spending as a share of the overall economy has been steadily increasing since the 1980s, as spending growth has outpaced economic growth. This growth is in part because of medical technologies, rising prices in the health sector, and higher demand for services. In 2020, when the COVID-19 pandemic began, healthcare spending rose rapidly in nearly all countries, as governments sought to mitigate the spread of the disease through COVID testing, vaccine development, relief funds, and other measures. Since then, spending has slowed but still remains higher from years prior. In 2021, the U.S. spent 17.8% of gross domestic product, GDP, on healthcare, nearly twice as much as the average OECD country. Health spending per person in the U.S. was nearly 2 times higher than in the closest country, Germany, and 4 times higher than in South Korea. In the U.S., that includes spending for people in public programs like Medicaid, the Children's Health Insurance Program, Medicare, and military plans, spending by those with private employer-sponsored coverage or other private insurance, and out-of-pocket health spending. All countries in this analysis, except the U.S., guarantee government or public health coverage to all their residents. In addition to public coverage, people in several of the countries have the option to also purchase private coverage. In France, nearly the entire population has both private and public insurance. In 2021, 8.6% of the U.S. population was uninsured. The U.S. is the only high-income country where a substantial portion of the population lacks any form of health insurance.
These charts are all misleading. The accompanying narrative is simply wrong. The U.S. has more money to spend on healthcare, and therefore this is going to skew us toward the high end. This, therefore, isn't as bad as it looks. It is bad, though, and of course could be better. Let's consider that in the U.S., about half your health coverage dollar, 47%, is wasted by big insurance. Add to that the fact that EMR, medical coding, and compliance reporting combined cost the average practitioner $77,000 per year each. If we had a new breed of insurance company that provides the EMR, thusly eliminating medical coding and automating compliance reporting, then we can conclude that we would save at least half from the cost of health coverage. The stated 17.8% of U.S. GDP would become something on the order of 8.9% on par with the least cost systems like the one in South Korea at 8.8% of their GDP. This is what we at Sentia are working on. We can replace everything the big insurance companies do with automation and simply charge a Netflix or Amazon-like subscription fee of $10 per month to manage the data and pay for your health care. These are real numbers. The difference between what the rest of the world is doing and what we are doing is automation.
Despite high U.S. spending, Americans experience worse health outcomes than their peers around the world. For example, life expectancy at birth in the U.S. was 77 years in 2020, 3 years lower than the OECD average. Provisional data shows life expectancy in the U.S. dropped even further in 2021. In the U.S., life expectancy masks racial and ethnic disparities. Average life expectancy in 2019 for non-Hispanic Black Americans, 74.8 years, and non-Hispanic American Indians or Alaska Natives, 71.8 years, is 4 and 7 years lower, respectively, than it is for non-Hispanic whites, 78.8 years. Meanwhile, life expectancy for Hispanic Americans, 81.9 years, is higher than it is for whites and similar to life expectancy in the Netherlands, New Zealand, and Canada. As a group, Asian Americans have a higher life expectancy, 85.6 years, than people in Japan. Avoidable mortality refers to deaths that are preventable and treatable. Preventable deaths can be avoided through effective public health measures and through primary prevention, such as nutritional diet and exercise. Treatable mortality can be avoided mainly through timely and effective healthcare interventions, including regular exams, screenings, and treatment. Since 2015, avoidable deaths have been on the rise in the U.S., which had the highest rate in 2020 of all the countries in our analysis. In 2020, the infant mortality rate in the U.S. was 5.4 deaths per 1,000 live births, the highest rate of all the countries in our analysis. In contrast, there were 1.6 deaths per 1,000 live births in Norway. Women in the U.S. have long had the highest rate of maternal mortality related to complications of pregnancy and childbirth. In 2020, there were nearly 24 maternal deaths for every 100,000 live births in the U.S., more than 3 times the rate in most of the other high-income countries we studied. A high rate of cesarean section, inadequate prenatal care, and socioeconomic inequalities contributing to chronic illnesses like obesity, diabetes, and heart disease may all help explain high U.S. infant and maternal mortality. Elevated suicide rates, which have dramatically increased during the COVID-19 pandemic, can indicate a high burden of mental illness. The U.S. has the 3rd highest suicide rate, while the U.K. has the lowest, nearly half the U.S. rate. The U.S. is an outlier in deaths from physical assault, which includes gun violence. Its 7.4 deaths per 100,000 people is far above the OECD average of 2.7 and at least 7 times higher than all other high-income countries in our study, except New Zealand.
Yes, we know that all Americans are fat, lazy, dumb, and evil. These illustrations are a little disingenuous, however. They could be mostly compensated for with less expensive health coverage and some patient education. If our new health insurance company also provided health and wellness functionality, and it does, with the teeth to say, if you behave this way, you will not receive the discounts that people who don't behave this way do, then we incentivize a healthier lifestyle and can check up on progress via measurements, lab data, and blood work. Let's think about smoking or a sedentary lifestyle. These are easily measurable, and we can provide the carrot in the form of an insurance discount that incentivizes healthy living. If we test and find nicotine in the bloodstream, the discount is removed. If we check the patient's resting heart rate and HDL, we have a good indication of his or her progress toward a healthy lifestyle. Everything else in this section can be attributed to mental health. Life expectancy and avoidable deaths are both due to a less than fully educated population and is easily mitigated with the health and wellness package discussed above. Here is a sample of our patient education. Notice the temperature gauge with the legend, showing why the patient's measurements are outside normal range and the explanation of problems, solutions, and other information below. The mental health part of this is a little trickier, and we have to assume that is due to culture. Other places don't have this macho, don't know, don't care, I'll do what I like attitude that we do here. We are working on a new module that will ask mental health questions and assign reading and homework based on the answers. Since this is part and parcel of the application, we can tell who has taken the tests and done the homework and incentivize that in the same way we do the health and wellness. Of course, this isn't a substitute for therapy, but with this we can identify the people in need of more involved help and get them access to a mental health professional. This proves that our assertion that money, or affordability of coverage, and education are the key factors in determining positive medical outcomes. In a completely unrelated note, we find it is interesting that the two lowest spending countries have the highest rates of suicide. If they had an automated mental health package like we described, maybe this wouldn't be the case.
Obesity is a key risk factor for chronic conditions such as diabetes, hypertension, and other cardiovascular diseases, and cancer. Issues that contribute to obesity include unhealthy living environments, less regulated food and agricultural sectors, lower socioeconomic status, and higher rates of behavioral health problems. The U.S. has the highest obesity rate among the countries we studied, where data was available, nearly 2 times higher than the OECD average. In 2020, 3 of 10 U.S. adults surveyed said at some point in their lifetime they had been diagnosed with 2 or more chronic conditions such as asthma, cancer, depression, diabetes, heart disease, or hypertension. No more than a quarter of residents in the other countries studied reported the same, and the U.S. rate was nearly twice as high as France's. Since the start of the COVID-19 pandemic, more people in the U.S. have died from the coronavirus than any other high-income country. For every 1 million cases between January 22, 2020 and January 18, 2023, there were more than 3,000 deaths in the U.S.
The graphics presented are interested in obesity, multiple chronic conditions, and COVID-19 death rates. All of these things can be mitigated by proper patient education and the carrot and stick approach. If one health insurance company is charging you less than half what the others are, you will use them. If that company offers significant discounts for science-based, lab-tested, healthy living, patients will get healthier. If they don't, they will pay for their lack of understanding, and that payment will cause the cost to go down for the rest of us. This is not difficult. If you want people to do something, you incentivize it. You give them a reason to do what it is that you want them to do. Then you explain step by step and in detail exactly what you need them to do, and they will go do it. We here at Sentia are unclear how we combat the unbelief in science and the refusal to take the vaccine for COVID-19. Probably, though, with the resources a major insurer possesses, an advertising campaign stating the truth about science and the vaccination would have some impact, particularly on social media or direct electronic communication like email or SMS text messages. As a payer, we would actually be incurring expense for an efficacious vaccination that will keep the patient healthy, reduce risks, and reduce costs for everyone. If the vaccine didn't work or had some nefarious purpose, we wouldn't advocate it, as we wouldn't receive any benefit and would have to pay for it.
While U.S. healthcare spending is the highest in the world, Americans overall visit physicians less frequently than residents of most other high-income countries. At 4 visits per person per year, Americans see the doctor less often than the OECD average. Less frequent physician visits may be related to the comparatively low supply of physicians in the U.S., which is below the average number of practicing physicians in OECD countries. The average length of a hospital stay in the U.S. for all inpatient care was 4.8 days, far lower than the OECD average. The U.S. had 2.8 hospital beds per 1,000 population, lower than the OECD average of 4.3. More than 2/3 of older Americans received the flu vaccine, similar to older residents of several other high-income countries, and more than the OECD average. The US, however, has one of the lowest COVID-19 vaccination rates among high-income countries. As of January 2023, 69% of the population were fully vaccinated, compared to 86% in South Korea, although rates are regularly being updated. The US does relatively well with cancer prevention. This is likely a reflection of extensive screening and detection, a key to diagnosing breast and colorectal cancers early and beginning treatment in a timely manner. The US and Sweden had the highest number of breast cancer screenings among women ages 50 to 69, notably higher than the OECD average. In contrast, just 43% of women ages 50 to 69 were screened in France. When it comes to colorectal cancer screening, the US exceeded the OECD average and had among the highest rates. Magnetic resonance imaging, or MRI, is a common and effective imaging technique for diagnosing and tracking the treatment of a variety of illnesses. The countries that use these specialized scans the most are the US, Japan, France, Norway, and Germany, with more than 100 scans per 1,000 people. The US has a high number of MRI units available to physicians, about 38 units for every 1 million people in 2018. That's the second highest rate in the world behind Japan, which has 51.7 units per 1 million people. While their clinical benefit as a diagnostic tool is well documented, MRIs are particularly expensive in the US, averaging $1,119. That's 42% more than the UK's average cost and 420% more than Australia's. And while MRIs are accessible in the US, Americans spend far more on them than their international peers do. Globally, rates of hip replacement are increasing as populations age and develop conditions like osteoarthritis, the leading reason for the procedure, which can substantially improve an individual's quality of life. Hip replacements are an important indicator of the prevalence of osteoarthritis in a population.
Clearly, these charts prove that when insurance removes impediments and pays for care, the US patients take advantage of it. The physician visits are low, probably due to the impediments and hurdles placed by old legacy insurance companies like copays and coinsurance. If the patient has to shell out for a visit, they might just say, "It's probably nothing," and wait to see if it clears up on its own. Influenza vaccinations, breast and colorectal cancer screenings, MRIs, and hip replacement incidents in the US are all world-leading, helping us to draw the conclusion that people are willing to engage and change behavior if their care is covered and they are informed of what exactly to do. Again, by lowering the cost and the impediments to seeing a doctor on a regular basis and by educating the patient on what they should be doing, can we rectify this situation. This is precisely what we are doing at Sentia Health. With our $10 per month plus the actual cost of the incurred risk, healthcare as a subscription service, we can save the patient at least half of the cost of their coverage and automatically prescribe education based on lab work and procedures performed. This is the only viable way to not only retain the best doctors in the world, but make care in the US both the best by utilizing those doctors in a financially efficient manner and educating the patients on their own personal responsibility in relation to their care. With the other parts of our service, healthcare as a service becomes healthcare as a platform that includes all that a patient, practitioner, and practice or hospital needs. We will discuss exactly what those are in a moment.
While the United States spends more on healthcare than any other high-income country, the nation often performs worse on measures of health and healthcare. For the US, a first step to improvement is ensuring that everyone has access to affordable care. Not only is the US the only country we studied that does not have universal health coverage, but its health system can seem designed to discourage people from using services. Affordability remains the top reason why some Americans do not sign up for health coverage, while high out-of-pocket costs lead nearly half of working-age adults to skip or delay getting needed care. The Inflation Reduction Act, which will help reduce the high cost of certain drugs and cap out-of-pocket costs for older Americans, is a step in the right direction. But it will take much more to make healthcare as easy to access as it is in other high-income countries. A second step is containing costs. Other countries have achieved better health outcomes while spending much less on healthcare overall. In the US, high prices for health services continue to be the primary driver of this elevated spending. US policymakers and health systems could look to some of the approaches taken by other nations to contain overall health spending, including healthcare and administrative costs. A third step is better prevention and management of chronic conditions. Critical to this is developing the capacity to offer comprehensive, continuous, well-coordinated care. Decades of underinvestment, along with an inadequate supply of healthcare providers, have limited many Americans' access to effective primary care. The findings of our international comparison demonstrate the importance of a healthcare system that supports chronic disease prevention and management, the early diagnosis and treatment of medical problems, affordable access to healthcare coverage, and cost containment, among the key functions of a high-performing system. Other countries have found ways to do these things well. The U.S. can as well.
Affordability is the top reason why some Americans do not sign up for health coverage. However, government programs capping payments are not the answer. The real problem with costs is the big, wasteful insurance companies and their policies that soak up almost half the money paid to them and that create work for the practice and the patient. The second plank in Commonwealth's plan is containing costs. This is a completely separate issue that we here at Sentia will address once we have the low-cost insurance set up. We can apply the same principles of streamlining and automation to the actual delivery of care that we applied to the payment process. The third plank of Commonwealth's plan is to manage and prevent chronic disease. There is absolutely no mention of how to do this, however. We have demonstrated a way to accomplish this and will continue to evangelize it. This paper has related several juicy tidbits but wholly fails to address root causes nor identify any solutions. The best we can tell is that the only people that completely cause the problem, the big, old, inefficient legacy insurance companies that waste half your premium, are also the only people with all the information necessary to solve the problem. Let's first define the real problem. We looked at the things that an insurer needs and the things it uses to produce its service. Our analysis concluded that the insurer needs a doctor with a national provider number, NPI, a procedure to pay for, and a way to transfer funds to the doctor for services provided. That is it. All the big buildings and impedimenta detailed above is only used to deny you contractually obligated coverage. Your insurer keeps 47% of your premiums on average and returns 53% of your premiums back to you as benefits. That is almost half of your premium wasted all by itself. If this insurer provided the electronic medical records system, EMR, to the practice, you could pick up the procedures performed and pay for them in real time. Then you wouldn't need humans at all. The coding and billing staff could be reduced to one accounts receivable person that makes sure that all the procedures get paid for. With this new piece of software, the insurer becomes a gently humming box in a cold room in a data center. No tens of thousands of employees, no big buildings, and none of the associated costs. This solves our first assertion. Money is one of two problems with the current system. If this new software included integrated health and wellness that details what is wrong with the patient and how to correct it, plus the mental health surveys and associated worksheets, and the insurer can give this package teeth by offering discounts for compliance, then we have a way to teach proper health behavior, test for proper health behavior using science, and incentivize healthy behavior by offering discounts for compliance. This solves our second assertion that education is the other root cause of the current problem. If this new insurer wanted to make the new software a real enterprise healthcare as a platform solution, it could add secure email to confer with each other and the patient, self-scheduling, further reducing the need for staff at the practice hospital level, questionnaires to be fully configurable by the practice and used inside the EMR for things that aren't structured like anything that isn't a diagnosis, modifier, procedure, or measurement. This could fully supplant the need for a specialty EMR. It could also be used for patient registration and satisfaction surveys or anything that currently requires a clipboard. Reporting would be anything from an inventory report to a full profit and loss statement. This also can be used for efficacy and compliance reporting. Instead of fingering through reams of paper and making tally marks in a legal pad, you click the button and you get a report. Telemedicine with integrated X-ray DICOM viewer. Sure, you can jump on a Zoom call with a colleague or a patient, but how secure is that really? Do you know? We don't. Also, you can't share images like X-rays or MRIs with Zoom or any other, and you certainly can't highlight a spot with a reticle or draw on a DICOM to highlight a particular structure. A fully fledged hospital practice management system. You may have noticed that we referenced P&L and inventory reports earlier. These are all a part of the Enterprise Resource Planning (ERP) package that we are building to further streamline and automate healthcare delivery. This will include fully functioning human resources, accounting, inventory, capital assets, and everything else that is needed to run the enterprise. Any enterprise, not just a hospital. Cutting out billing, coding, and collections, eliminating the need for efficacy and compliance reporting, and providing a fully functional EMR to the practice or hospital saves the average practitioner over $70,000 per year. That will certainly push us over the 50% saving threshold. In this article, we have identified real, quantifiable problems with the U.S. healthcare system, boiled those things down into their root causes, and given a reasonable, simple way to mitigate those root causes. Saving the consumer 50% on his or her health insurance makes us one of the most affordable globally, comparable to the least expensive worldwide, and with far, far better care. We have proven also that if you show the patient what needs to be done and pay for it, they will do it, as the influenza vaccination rates, screenings for breast and colorectal cancer, and MRI usage shows above. Incentivizing healthy lifestyles and mental health will put us on par with the outcomes of the best in the world. Nobody else on the planet offers financial incentives to promote health. This should actually put us ahead of the curve in that regard, with a large percentage adopting the program. With incentivizing a healthy lifestyle, the overall cost of health coverage should decrease for entire populations, further reducing the bill for health coverage. Once we have completed the move to this clearly superior system, we will have achieved through financial incentives, a single-payer system. Nobody in the country, and probably the world, will want to go back to the old spreadsheet, banker-driven health coverage systems, particularly when they are double the cost. Yes, health insurance in these developed countries work exactly the same way ours in the US does. They just remove the profit motivation and run it as a government agency. That won't work here. By removing the spreadsheets and bankers and going to a flat rate data management system, we can start to move toward a pay-for-health or value-based system and away from a pay-for-procedure system. We have shown a way to mitigate the root causes of healthcare failure in the US. We have shown a way to reduce the cost of health coverage by at least 50%, and we have shown a way to incentivize healthy behaviors and choices. With these two things, we will be not only the cheapest medicine in the world, but also the best. We already have the best doctors and the best equipment. We just need to implement the above detailed framework to possess all the tools necessary for success. We have this system in prototype now, fully functioning. The ERP system and the mental health module are slated to start production early in 2025, but are fully designed and the database is built. Contact us here or on our site, and we will be happy to provide a demonstration of the fully functional prototype. Read the text version of this video on our newsletter site, sentiahealth.substack.com, or click the link to it in the pinned comment. All of the referenced material will also be linked in the pinned comment. We appreciate your attention and help with promotion and invite you to tell us your thoughts in the comments. We will make every effort to read and answer every comment. Part of the reason we do this is to educate you and help you to educate others. Help us help you and every insured person in the world by clicking like and subscribe, telling the algorithm to show this to more people. Until next time.